Good morning. My name is Gopal Singh and I am with HRSA's Office of Health Equity. I will serve as a coordinator and presenter for this session. The session will include two presentations. Dr. Elijah Martin and I will present on health, mortality, and social inequalities among African Americans. In the second presentation that follows, Dr. Shanita Williams will talk about policy solutions to advance health equity among African Americans. Slide 2. In this presentation, we will look at trends in life expectancy, infant mortality, maternal mortality, and mortality from major causes of death among Black or African Americans in comparison to other racial and ethnic groups, and provide possible explanations for persistent racial and ethnic health disparities and disadvantaged socioeconomic and health position of African Americans. For this presentation, we analyze a number of federal databases, including the National Vital Statistics System, consisting of births and deaths, the National Health Interview Survey, the American Community Survey, Census Bureau's Decennial Census, and HRSA's Uniform Data System, UDS, and the Ryan-White HIV/AIDS program data. Mortality rates are age-adjusted, and racial and ethnic disparities in mortality or disease prevalence are presented in terms of relative risks, rate ratios, and percent change in rates. Slide 4. This slide shows that African Americans and other racial and ethnic minorities are disadvantaged in terms of social and economic attainment. In 2017, African Americans had at least 2.3 times higher poverty and unemployment rates than non-Hispanic whites. Racial and ethnic disparities in educational attainment were also large, with 23% of African Americans attaining a college degree compared with 36% of whites and 54% of Asian Americans. In 2017, 10% of African Americans lacked health insurance compared with less than 6% of non-Hispanic whites. Slide 5. This slide shows that among major racial and ethnic groups, African Americans have the second lowest life expectancy after American Indians and Alaska Natives. In 2017, African Americans had a life expectancy of 76 years, 3 years shorter than the life expectancy of almost 79 years for non-Hispanic whites. Slide 6. Life expectancy has improved substantially during the past 7 decades, but the Black-white disparities have persisted. For example, in 1950, the life expectancy of Black men was 59.1 years, 7 years shorter than the life expectancy of 66 years for white men. In 2017, the gap was reduced to 4 years, 76.7 years for white men and 72.6 years for Black men. Slide 7. Although infant mortality rates have declined impressively for both white and Black infants over the past several decades, the racial disparity in infant mortality has continued to grow in relative terms. In 2017, the Black infant mortality rate of 10.8 was 2.2 times higher than the rate of 4.8 for white infants. Slide 8. This slide shows a consistent inverse educational gradient in infant mortality rates for both African Americans and whites. However, at each level of maternal education, Black infants had almost twice the mortality rate of the white infants, with the racial disparity in mortality being the largest among infants born to college-educated mothers. Slide 9. Maternal mortality declined by 68% between 1969 and 1998. However, the maternal mortality rate nearly doubled between 1999 and 2018. The risk of maternal mortality remained 2.3 to 5.3 times higher among Black women compared to white women during the past 5 decades. In 2018, the maternal mortality rate for Black women was 34 deaths per 100,000 live births, 2.4 times higher than the maternal mortality rate of 14.0 for white women. This slide shows declines in all-cause mortality rates and mortality from several leading causes of death between 1990 and 2017 for both African Americans and whites, except for kidney disease mortality, which increased markedly for both racial groups. You can also note that mortality rates among whites from suicide and from unintentional injuries, that is accidents, also increased between 1990 and 2017. The most prominent racial disparity in mortality was observed for homicide and HIV/AIDS, as African Americans experienced 7 to 9 times higher risk of mortality than their white counterparts. Slide 11. HIV viral suppression rates are significantly lower among African Americans, American Indians and Alaska Natives, and Native Hawaiians and Pacific Islanders compared with non-Hispanic whites. Although all racial and ethnic groups experienced improvements in viral suppression rates between 2010 and 2017. Slide 12. In 2017, among the health center patients, African Americans had the lowest rate of controlled hypertension, 56%, that is, compared with 65% for non-Hispanic whites and 68% for Asian Americans. 13. The 2017 UDS data show that 35% of African American patients in health centers had uncontrolled diabetes compared with 30% of non-Hispanic white patients. Slide 14. In terms of health risk factors that contribute to increased morbidity and mortality, African Americans fare worse than their non-Hispanic counterparts, non-Hispanic white counterparts. Compared to non-Hispanic whites, African Americans have higher rates of smoking, obesity, physical inactivity, and inadequate food and vegetable intake. Although African Americans have higher rates of breast and cervical cancer screening, they report lower rates of colorectal cancer screening than whites. Slide 15. To summarize then, despite improvements in overall health and well-being, African Americans remain a disadvantaged segment of the US population in a number of key health indicators and in socioeconomic and living conditions. Although reduced smoking, greater physical inactivity, lower obesity, healthy diet, and increased access to and use of quality healthcare services can lead to improvements in the health of African Americans, these factors are themselves primarily influenced by broader, more upstream social determinants such as education, income, social and welfare services, affordable housing, job creation, labor market opportunities, and transportation. Addressing inequities in these social determinants should be an important policy focus for tackling racial and ethnic health disparities, particularly among African Americans relative to white Americans and other racial and ethnic groups. That's all I have. I will turn it over to Dr. Elijah Martin to describe his HBCU study on African American students' attitudes towards smoke-free campus policies and their smoking behaviors. After Dr. Elijah Martin's remarks, Dr. Shanita Williams will deliver her presentation. We look forward to addressing any comments or questions that you might have at the end of the two presentations. We can be contacted by email. Thank you very much for attending the session. Over to Dr. Martin.
Hello. Hi, my name is Elijah Martin, Captain Elijah Martin from the Health Resources Service Administration, Office of Health Equity, and I am honored to be able to present information regarding smoking-free policies and smoking behaviors in HBCUs. I am doubly honored to be able to be a part of this presentation and this program and this the HBCU week because of my privileged to have graduated as an undergraduate student at Fisk University and HBCU in Nashville, Tennessee. In this original research on smoking free policies and behavioral behaviors in HBCUs, this is limited research that was done at HBCUs in the United States. The research included 220 African American undergraduate and graduate students enrolled at 2 urban HBCUs who participated and completed an online and in-person survey conducted between October and December of 2019. This study examined students' attitudes towards differential smoke-free campus policies and their smoking behaviors. Next slide, I'd like to discuss a little bit more about the significance of this study and at HBCUs. In this study, I looked at whether students at comprehensive smoke-free policy HBCU schools smoke more or less than students at a regular smoke-free HBCU school. The comprehensive smoke-free policy CSFP is defined as no smoking allowed anywhere on campus at any time, including tobacco use. The other HBCU that had a regular smoke-free policy is defined as no smoking allowed in the buildings, but smoking is allowed outside in designated areas on the campus. The focus of this research was to determine whether an association exists between students' attitudes towards the smoke-free policies and students' reported smoking behavior. Public health officials clearly note tobacco use among United States citizens is the leading cause of preventable death and disease, and it is estimated that almost 500,000 citizens die from disease caused by tobacco smoking. Racial and ethnic populations are at high risk for using tobacco and tend to bear an unequal share of the human and economic costs of tobacco use when compared to Caucasians and other racial and ethnic groups. African Americans have a higher rates of lung cancer deaths, higher mortality rates from several chronic illnesses caused by smoking, and a disproportionate share of tobacco-related chronic illnesses. These higher rates of tobacco and smoking-related illnesses and death persist even though African Americans have lower smoking rates and start smoking at an older age. So racial and health disparities is critical to focus on because they have persisted for African American and Hispanic Latino students attending higher education institutions in the United States. Several researchers recommend further research to include surveillance of tobacco control policies, identification of factors that facilitate and impede policy adoption, and the evaluation of impact of specific tobacco control policies on smoking prevalence. And finally, I want to note that implementation of comprehensive 100% smoke-free policies at institutions of higher education schools is considered to be the best solution to the problem. And looking at the results of this particular study, there were significant associations for this particular research question, and a majority of the students, both undergraduate and graduate, either strongly agreed or agreed with the statement that they have positive feelings about their school's smoke-free policy. The majority of the students also at both schools reported that the smoke-free policy had not affected their smoking behavior. The multivariable analysis did not indicate a statistically significant association between students' attitudes towards smoke-free policies and their smoking behavior, and further, the difference in smoking prevalence between the two schools was not statistically significant by policy type. To conclude, it is noted from the study that a smoke-free policy is essential to ensuring a healthy learning environment, and it is important to understand the context-specific factors that contribute to smoking behavior among African American students in order to develop effective programs for HBCU students. Despite significant findings in this study, further research must be done on the effectiveness on the current processes and benefits of outcomes, as well as disadvantages and weaknesses of existing programs and policies, smoke-free policies being implemented at HBCUs. There continues to be a shortage of research on HBCUs' attitudes towards enforcing college smoke-free policies. And it would be interesting to learn more about the different factors that influence students' use of tobacco products. Thank you for allowing me to share some information regarding this critical health issue around smoking and how comprehensive smoke-free policies can serve as a effective intervention to deter or even encourage students to not smoke. I can be reached on the email at emartin@hrsa.gov if you have additional questions, and also Dr. Singh information is available at gsingh@hrsa.gov. It's again an honor to be a part of being able to share this information, more significantly because I am a product of an HBCU, and I look forward to continue this life's work of doing the kind of research to spread the education about the significant negative impacts on the health outcomes of African Americans as it relates to tobacco use. Thank you.
Hello and good afternoon. I am Shanita Williams, and my presentation will be on the topic of health in all policies. What if I told you that the decisions being made at your local school board or city council meetings can affect the quality and length of your life and the lives of your family and friends? In my presentation today, my goal is to provide some insight on why public policy at all levels, not just the federal level, is a determinant of health and health equity, and why the right public policies is a key solution to advance health equity among African Americans. And a spoiler alert, those decisions being made at your local school board and city council meetings absolutely impact you and your community's health. I have three overall objectives. First, to describe why public policy is a determinant of health and health equity. Second, to articulate why a health in all policies approach is essential for reducing health inequalities and achieving health equity among African Americans. And third, to present examples where states and cities have adopted health in all policy approaches to improve the health of African Americans. I will begin with definitions of policy and policy strategies. First, policies are not laws. Laws are standards, principles, and procedures that must be followed. Laws are created to implement justice in society. While there are various types of laws, like criminal, civil, and international laws, the distinct feature of all laws is that they are not optional. Policies, by contrast, are choices. Choices made from among a set of options to achieve certain goals. What drives policy choices are preferences, which leads to the question, what are our societal preferences? And what are our society's goals? And this is where it can get interesting because our society's preferences and goals are often driven by unspoken values and frequently are not made explicit. This is a key feature of policies. However, policies must be implemented to have an impact on society. Therefore, the right public policies can address the increased concentration of health risks in communities of color. They're able to build upon and leverage community strengths. They can improve they can improve access to health enhancing resources, and they can create healthier communities for increased quality and longevity of life. Health in all policies is founded on the principle that policies and policy decisions that affect health often lie outside of the healthcare sector. A health in all policies approach crosses sectors. It systematically takes into account implications of policy decisions. It seeks synergies, avoids harmful health impacts, and its goal ultimately is to improve population health and achieve health equity. Now, I really like this framework that was developed in 2014. In this visual, the key takeaway is that clinical care alone is insufficient in securing good health and long life. In contrast, as you will see on the left side of this schematic, it is policies and programs that drive health factors that in turn determine health outcomes, specifically the quality and length of life. 50% of those health factors are within the domains of physical environment and social and economic conditions. So factors such as education and employment, income, housing, transportation, which by the way are closely linked to one another, it is these factors that contribute most to our health. Health behaviors contribute another 30% to our health, while only 20% of health outcomes can be attributed to clinical factors, clinical care, assuming that you can get the right access and to high quality clinical care. Therefore, 80% of the differences or inequalities are due to economic and social conditions and health behaviors. It is African Americans and other racial and ethnic minorities that are most likely to experience disadvantages within these critical social and economic conditions that affect health. However, it is even more entangled when you factor in the notion that health behaviors and lifestyle choices are often shaped by the availability of social and economic resources. Your education and income influences your lifestyle choices. This even seeps into the 20% of the clinical care domain. Clinical care, its availability, and the quality of that care is also influenced by social and economic resources. For example, African American adults are more likely to report that they cannot see a doctor or are unable to afford healthy environments because of cost. And this is why health in all policy approach matters. At the very foundation of this graphic, the key drivers that sets all of this in motion are policies and programs that results from those policies. Health equity is the notion that everyone has a fair and just opportunity to be healthy. But if you really think about it, in order to achieve health equity, we must remove those obstacles to health, such as poverty and discrimination. And people need access to good jobs with fair wages. They need a quality education, housing that is adequate and stable, and safe environments, and yes, quality health care too. So looking at these variables, these are the determinants of health. We will not get to health equity for all, and especially for African Americans, until we begin to remove these social and economic obstacles and increase access to these health enhancing attributes of society. I really also like this graphic too. This 2019 graphic shows why we need policy changes to address population health and health equity. Policy can be leveraged upstream to impact the health of populations because it is through policy that society's social and economic conditions are shaped, and these impacts are long-lasting across generations. Downstream is where individual actions and behaviors occur. At midstream, we see our public and private institutions getting involved in health beyond the individual level. Hospitals and clinicians are now conducting social needs assessments and asking questions about housing conditions and access to food, something that has not always been done. But this is still not far enough. We have to continue to move upstream towards the population level where policy actions happen in order to truly achieve health equity. Now, getting back to the school board and city council meetings where policy choices are being made, those local, social, and public policies are what impacts the community and neighborhood conditions in which we live. When I started this presentation with the comment that your local school district meeting or city council meeting can shape the quality or length of your life, it is through policy making that this becomes a reality. Health differences or inequalities caused by poor economic and social conditions are more common among African Americans than whites. What is important to note here is that these are population level disparities, not individual disparities. Therefore, it is not enough to say, well, I personally make the right lifestyle choices. By nature of you being an African American, you inherit these increased health risks. Why? Because the root cause of these risks are generations in the making and often lie outside of your personal control. So what does this all mean then? Well, as a population, African Americans share increased disadvantages in the quality and length of their life. Today, the leading causes of death among African Americans are heart disease, cancer, and accidents. African Americans are more than twice as likely to die from heart disease, including hypertension, diabetes, strokes, compared to whites. African Americans have the highest mortality rate for all cancers combined, compared with any other racial and ethnic group. The death rate for babies born to African American mothers are twice that of babies born to mothers of any other race or ethnicity. And the urban legend or myth that Black folks don't kill themselves is just that, a myth. African American men and women are indeed dying by suicide at alarming rates. Now, I want to take a moment to focus on lower life expectancy among African Americans as a critical inequality that has been historically shaped by discriminatory practices and policies. The Virginia Commonwealth University, in partnership with the Robert Wood Johnson Foundation, created a series of life expectancy maps. They were developed to illustrate that opportunities to lead a long and healthy life can vary dramatically by neighborhood. Here is a map of Atlanta, Georgia, on the left of your screen, and Washington, D.C. on the right. If I were to ask any of you listening to this presentation to give me more context for the disparities in life expectancy by neighborhood that is observed on each of these two maps, I suspect some of you could provide those insights because you or your parents or grandparents may have lived in these areas. Those of you familiar with Atlanta would say, oh yes, those neighborhoods above Interstate 20, where you see average life expectancy peaking at 82 to 84 years, that's Buckhead, Piedmont Park, and Druid Hills. It's where the old families live, or that's where Emory University and the CDC are located. And the neighborhoods south, east, and west of I-20, with as much as a 13-year drop in life expectancy, in these neighborhoods you will find Atlanta's lower income residents, our HBCUs, the West End, and where people of color typically live, setting aside, of course, the disruptive influence of gentrification that is happening now in many parts of the east and west side of the city. In other words, there is a different lived experience based on population demographics, and you will see a different set of policies between these Atlanta communities that not only drive life expectancy, but also quality of life. In the same way, if I were to overlay an Atlanta housing values chart over this same map, you will see a similar distribution of property values tracking closely along with life expectancy. The higher your housing values, the longer you would be expected to live. In DC, it's a similar story. Where I live now, you would ask, and folks would say, yes, everyone knows if you live on the red or blue lines, you will have a different life experience when compared to those who live on the green line. They would say also, but it costs more to live on the red or blue lines. And it's not just DC or Atlanta. This pattern is repeated across multiple cities and towns throughout the United States. Have you ever heard of the phrase, the wrong side of the railroad track? Now, the railroad tracks have been replaced with the metro, but the story remains the same. It matters where on the metro line you live. Elizabeth Ananot wrote a wonderful paper titled The Wrong Side of the Tracks, The Causal Effects of Racial Segregation on Urban Poverty and Inequality. In her paper, she presents detailed evidence to show that after slavery ended, railroad tracks were purposely laid to segment and segregate African American communities from white communities, and hence cut them off from key social and economic resources. The Washington Post published a fascinating article a year ago detailing how the legacy of those railroad policy decisions are still manifesting today in terms of lower life expectancy among persons living in segregated African American neighborhoods and communities. The health differences or inequalities that we are seeing today flow from historical policies created over 100 years ago that were designed to increase racial segregation and concentrate poverty in African American neighborhoods. This is in part why some neighborhoods are so much healthier than others. We know that neighborhoods that promote health are typically racially and ethnically diverse, that they reflect urban designs where the homes are built smaller, they're energy efficient, they are close to jobs and public transit, that they allow retail and services within walking or cycling distances, and they have robust non-car transportation networks that connects homes, workplaces, and other economic activity centers. These are the healthiest neighborhoods, designed through intentional public policy making. Now, there are evidence-based, data-driven policies that have been shown to influence the health trajectory of disadvantaged populations. Policies that focus on economic development and opportunity are game changers. Earnings and asset development programs have been shown to be effective in increasing economic self-sufficiency of low-income families and stabilized personal incomes. Similarly, equally critical are those policies that focus on child and youth development. Family strengthening programs and investments in early childhood education are key. The major cause of child poverty is adult poverty, fueled by a caregiver's low education attainment, unemployment, housing instability, and food insecurity. These types of policies and programs are able to link families to the needed support and benefit services that are essential for health. And as I have been making the case throughout this presentation, policies that address neighborhoods and the built environment can also address health inequalities among African Americans. Neighborhood strengthening policies and programs can improve health supporting features of neighborhoods, such as creating affordable and safe housing, quiet streets, green spaces, walkable communities, and connect to key services. Now I want to now highlight two specific examples of cities that have adopted health and all policy approaches to address inequalities that affect African Americans. This first example is in Richmond, Virginia. The Center on Society and Health at Virginia Commonwealth University produced a health equity report in 2016. The report highlighted that African Americans in Richmond City were more likely to live in poverty, more likely to suffer from preventable disease, and die younger than whites. And there was a 20-year gap in life expectancy among census tracts segmented by race. The report specifically called out disparities in neighborhood conditions as contributing to the inequalities in health among African Americans and Latinos when compared to white residents. They also called out highway construction and public housing as key factors that have contributed to alarming disparities. So what did Richmond do? Thankfully, they didn't ignore the report. Instead, they mobilized the private and public employment sectors who had a vested interest in Richmond's success. Major employers have a business interest in improving the health of their workers and curbing healthcare costs, and many now recognize that investments in the community are an important business priority as well, not just in terms of a social mission, but also it is critical for the business financial bottom line. In this case, General Electric, with its gas and power unit headquartered in Richmond, stepped up and is working with a cross-sector coalition of community partners to improve the health and well-being of African American and Latino communities in the city. A second example is with the City of Chicago's Healthy Chicago 2.0 initiative, aimed at deepening the city's commitment to community representation and racial equity. The Healthy Chicago Public School Initiative was designed to enhance student achievement by removing health-related barriers to learning. The school system hired a chief wellness officer that reports directly to the commissioner of the City Department of Health. Why is this important? Because they know, and we know, that children who live in unsafe, violent, and unstable neighborhoods and kids that come to school tired and hungry cannot learn. These two exemplars appear to be working. I also want to share with you a cautionary tale. That is, to advance health equity that is sustainable, you must demonstrate the business case of eliminating population health inequalities, meaning the success of any health equity effort depends on how those efforts align with larger economic interests and whether there is a return on investment baked into the initiative. The bottom line is that it has to be about more than it's the right thing to do. Take the case of food deserts in South LA. In the mid 1990s through early 2000s, South LA experienced an explosion of fast food restaurants. This explosive growth was driven by commercial interests and the belief that fresh food enterprises and high quality supermarkets would not be marketable in a predominantly working class African American and Latino community in South LA. It was in this context that grassroots healthy food advocacy efforts began. The movement steadily gained momentum, and over a decade later, those early advocates were successful in securing a moratorium on fast food restaurants in South LA. In 2008, the South LA ban was unprecedented in that it was the first to connect a public policy to the obesity epidemic. The ordinance didn't close existing restaurants, but it did block construction of new standalone fast food restaurants in an area with over 700,000 residents. It felt like a huge victory at that time. However, what those grassroots advocates did not expect and were not prepared for was the blowback, which came immediately. The moratorium ultimately failed. The failure was due in part to the intense lobbying and outcry from the restaurant industry. In fact, there was a headline in an international journal that read, "Obesity rates for residents of South LA only increased after a city imposed moratorium on new fast food restaurants." On the surface, this outcome would have been very discouraging. However, just 2 weeks ago, I was watching the morning news, and there was a spotlight on a local healthy foods policy initiative. And where? South LA. The policy-driven program is called the Healthy Neighborhoods Initiative, and it's part of the Healthy Food Network in LA program. The network members, which include entrepreneurs and second-generation corner store owners, are taking on the challenge of providing healthy fresh food options in urban food deserts like South LA. But this time, they are not going it alone. They have the backing and resources from the business community and local California universities that provide support in terms of grants and business management expertise, among other resources to support their success. Therefore, this is also a cautionary tale on the dangers of giving up on a community too soon. The final key takeaway, and also this is my opportunity to end this presentation on a positive note, is that if you keep at it, you will eventually gain some traction. If you embrace a health in all policies approach to achieve good health and a longer life, and stick with it, and bring along with you cross-sector partners with a shared commitment to the African American community, then you will absolutely be able to achieve positive and sustainable results. That's all I have. I will stop here. Thank you.